Good afternoon, everybody. All those in the audience, welcome to today's presentation, Models for Community and Peer Talent and Development. This session is going to be moderated by Andy Wade, and in the audience with him will be Blanca Campos, Vice President of Policy and Government Affairs for the Association of, the Community Behavioral Healthcare Association of Illinois. Donell Barnett, Deputy Director for Clinical Operations at the Illinois Department of Human Services, Division of Mental Health, and Pryscilla Bolander, Program Manager for Sinai Urban Health Institute. There will not be time at the end of the session, probably, for questions, so
you could kind of do that on the fly. I know that. Yeah. Am I live? Yeah.
And then at the end of the session, I will remind you how to get a copy of the presentation slide that we're showing here. And at this point in time, it's my pleasure to turn this over to Andy Wade, who will start the event. So go ahead, Andy.
All right. Well, I want to welcome everybody, and I'm going to say we had some issues with the conference in terms of people being able to access some login issues. So our plan will be, because we're going to have a good conversation, we want to make sure it gets out broadly, to look for ways to push this link out. It's basically the pre-recorded, TV show kind of thinking. So wanted to work on that. This is a session that is on, it's called Community Models for, it's talent, I'm sorry, I don't have it right in front of me. Investing in talent development, and it's looking at community and peer communities as a source of talent, and what do we need to do to develop that. I just wanted to share a little bit of background about how we kind of came to this conversation at NAMI. This actually, from my end, actually started before I was at NAMI, when I was working out on the west side of Chicago with some folks that were doing gang intervention, and noticed in that the people that were my friends that were helping, they were helping these kids, they're helping me too. But some of the most gifted therapists weren't therapists. We were trying to build a clinical team kind of on the fly, because it was a response to some really challenging circumstances and a lot of trauma exposure. And some of the best people that we had, might have had a GED or maybe a little college, some ACEs training, and they were doing wonderful work. So it just got me curious about what would it take to develop a workforce that includes that. When I came to NAMI, I got to know the peer workforce, and this is a whole. And we have, I think, Trisha's in the guest room. We're really interested in the peer, in investing in peers as a source of strength, especially as we look at where the shortages are. So this is a conversation about talent development. The frame for this is we began looking at it, we began to get confused. You come to something with a simple idea, and then you find out how little you know. And that's kind of how this conversation came about. In the course of learning about it, we began to make some friends. Siba is a longtime friend. We are a grantee of DMH and have really been really enjoying developing that relationship, especially this administration in particular. Is really committed to not just to addressing workforce, but to addressing the workforce that looks like Illinois. And then in the course of our casting about, and we met SUI, Sinai Urban Health Initiative, which is developing a community health worker model and is interested in mental health. SUI was convening people that were looking to get prepare people for a health workforce in Latino areas. So we began to meet kindred souls, and people were working on it. But then when the workforce development bill passed, and I'll ask Blanca to talk about it, suddenly there's opportunities to do things that are unheard of. And in the midst of this, we have a pandemic and greater demand than ever. So it does feel like we've reached a moment in time where this is not a conversation. We're not spitballing. We're sort of designing in dialogue what needs to happen, because I think it can happen. I don't know if people caught yesterday's session, the keynote with Dan Gillison from NAMI and Grace Ho and Rick Estrada, who does the Metropolitan Peace Academy, among many things. But there was a really consistent, this came up, and this has come up in many sessions that are unrelated to this. So we've got a moment in time. I want to reference another session that happened yesterday, because that is the frame for what we're going to talk about today. As we began to get confused, we asked for clarity and met some people, a psychologist who has convened a network of like 1,000 people, therapists, people of color, that was a support community. She's also a DEI consultant. And so she had a session with Marvin Lindsay, Blanca's associate, and a practitioner, and Representative West, to talk about what are the big frames. If we're trying to build legislative support, you already have legislative support for the issue, but between the issue of workforce important and all of the specificity we need, you get lost. I get lost. So what they came up with in that workshop was pillars. And the title was Architecture for an Inclusive Behavioral Health Workforce. And so they're thinking of it structurally. And three themes in all of the conversations that people have been having tend to jump out. One is mentoring, the other is career pathway, and the last piece is money. And so to develop those ideas out, mentoring is something Leela actually put it out. She's a African-American woman. She's just talking about community and being, in her context, but saying how important that was. And she was talking about her experiences going through the field, how isolating it was, and forming I'm fortunate, if I were to go to school, I would have a community. I just have a community, that we can't assume that. And Marvin, who is a friend and a guy I learned a lot from, he mentors mostly, I think it's men. He has a mentoring program that's at UIC that he does to help get more men of color into the program. They came about, UIC is, in an urban community, and they were graduating very few MSWs that reflected their own neighborhood. So what came out of that was that mentoring is not just a thing that's nice. Mentoring needs to be a system that begins from, fourth grade and to retirement. And so what does a systematic approach to mentoring and community of support look like? So mentoring and community support being one strand. The second strand would be a clearly defined pathway. And we're borrowing language from the workforce development field, career pathways, which means a thing, but it's talking about what's an approach that starts where people are and creates the stepping stones and systems of support that need to happen. So this is really about jobs. What we want people into jobs. What do those jobs look like? How do we know the jobs are connected? What leads to what? So career pathways, clearly defined career pathways. And what Pryscilla, I know, can talk about is there's a lot of confusion. There's a lot of great work, but there's a lot of confusion. And then the last is sustainable resources. How do we pay for it? One of the groups I worked with, they desperately needed someone. All they needed was like a little bit of money to get an LCSW in so they could get clinical interns. It was all done by private philanthropy, and they didn't get it. So they didn't have it. So we really need to talk about money. So with that framework, I wanted to first of all just ask the panel about some models. Like, what are some things that we could learn from that exist right now that can grow? The other thing that we're going to talk about is what are some things that come from adjacent sectors. Mental health is mental health. Then there's primary care / community health. Then there's this whole other world of workforce that, could do health if they were asked to at some level. So questions about what do we get from different systems, and also who's not at the table today. So today we're talking about a few different models, sort of traditional models, and we'll ask Dr. Barnett to speak about that, world of community health, and we'll talk about who's missing after that. But first we wanted to have Blanca paint the picture, because Blanca, right now, we seem to have an opportunity. Could you just tell us what's happened and why that matters?
Absolutely. Thank you so much, Andy, for having me. So just to begin quickly about CBA, our Community Behavioral Healthcare Association represents safety net mental health and substance use providers across the state. Our members serve Medicaid eligible adults, children, and families, as well as folks who are uninsured and undocumented. They offer full continuums of services, including outpatient services like counseling, therapy, case management, group homes for adults with mental illness, and crisis for children and adults, among many other services. So this issue is not new, particularly for community-based mental health agencies. The behavioral health workforce shortage was already at crisis levels before 2020. So back in 2018, our association initiated resolution that passed unanimously in the House, declaring a behavioral health workforce shortage emergency. That resolution included some recommendations, one of which was to create the Behavioral Health Workforce Education Centered Task Force, which our association chaired, to study the behavioral health workforce landscape here in the state and provide recommendations to grow, recruit, and retain a qualified, diverse, importantly, and evolving workforce. Regarding the peer workforce, the task force specifically investigated barriers to optimal integration of peers into care teams and to career advancement within the peer workforce. And some of the things we learned that I'll highlight are things that you just talked about, Andy. So to the extent that the peer workforce has grown, it has primarily expanded through entry-level, low-wage, part-time positions. The peer workforce also faces many of problems familiar throughout the behavioral health sector, a burdensome credentialing process, difficulty integrating into a medical model, and the need for pipeline and career pathways, which is so important. Additionally, peer support providers work under many different job titles, and career development paths are unclear. So without more attention to workforce advancement, the peer workforce model is not sustainable. Furthermore, funding, as we talked about, funding for peer support is fragmented and unreliable. Medicaid enrolled providers may be able to use some Medicaid revenues to support peer professionals, but most peer support services themselves are not directly reimbursable in Illinois. And finally, laws barring people with criminal records from working in certain healthcare facilities or obtaining certain licenses create specific barriers to growth in the important sector of specialized peer support for people leaving jails and prisons. Importantly, of course, and most importantly, the task force also identified some possible solutions to these issues that were identified. So developing mid and managerial level peer support positions for advanced peer professionals, expanding supported education to remove barriers, including financial barriers, which Dr. Barnett will be speaking about, to obtaining college and graduate degrees necessary for career advancement in clinical settings, building higher education pathways that explicitly cultivate the transformation of lived experience into experiential knowledge through synergistic formal training, education, and mentored practice experience to advance peer skills and to challenge attitudes that downplay the contribution of formal education to the peer to the value of peer support. And lastly, and very importantly, again, that funding piece, the state should expand the capacity in peer recovery and other non-traditional behavioral health roles, and should authorize community-based agencies with certified peer specialists to bill for certain Medicaid, substance use and mental health services. As Pryscilla will talk about, we saw huge advancement on the community health worker front this past session, where community health workers would be able to bill for Medicaid, which is huge. So there's a lot of work to be done, but there's also huge opportunity for growth for this essential workforce, particularly at a time where more models call for the inclusion of peer professionals. You mentioned in one of the other sessions, the rollout of 988, which is going to be our new suicide prevention mental health crisis line. And these mobile crisis response teams are required to have a CRSS on the team. Obviously, you have your ACT models and other models that also require peer workforce. So there is a lot of opportunity. I think there's a willingness on behalf of this administration to push workforce across the board, but specifically around the peer workforce. So those are my comments for now.
So I think I wanted to ask you, the recommendations are now passed, right? In law. So the Workforce Education Center is established, right?
Yes, so it is so as you can imagine, we looked at various aspects. We looked at different provider types, one of them being the peer workforce. What did pass this session, so loan repayment passed, we filed legislation, passed loan repayment legislation back in 2018. What passed just now in this session, it was included in the Black Caucus Healthcare Pillar, was the Behavioral Health Workforce Education Center, which is huge. It's actually going to be fully funded. And the center will be tasked to build this pipeline. It's going to be tasked with so many different initiatives, training, supporting the current workforce. So I'm sure Dr. Barnett will talk more about that, because it is actually the Illinois Student Assistance Commission and DMH have been working together. They've identified the institutions that will be housing this center, but intentionally SEBA drafted the legislation where we wanted this to be kind of like a hub and spoke model, right? Where you have your main entity is going to be the coordinating body, and then you have your spokes across the state, because while we do have these overarching issues, we do know that there are unique challenges in every community. So that was a very important our work, but that did pass. It is going to be fully funded, which is huge. But it's go ahead, sorry.
I want to get into the other folks of the conversation. The reason it's important, and I wanted to ask about it, is what it means is that there's an institutionalized home for the work that we do now. And, like when I was looking at it, Marvin was presenting on it today, and, how the depth of it, some of us have experience building those kinds of structures and networks. I mean, look at this event. And we want to just help. So it's really exciting, because what it means is that we do all this work, we have these conversations, and sometimes it's just like, boy, I wish we could do this. We can do this. And this is a place where it can go to live. So really great work with SEBA. So I wanted to ask Dr. Barnett. Dr. Barnett is a Deputy Director of Clinical Operations for the Division of Mental Health, and really has beyond his background, just a really strong vision for what's possible. Some of the things I've heard out of your mouth the short time we got to know each other, really impressive. You could tell you're thinking about it, so I love that you're passionate. So could you just tell me what's the department got going on the workforce broadly? And then, it sounds like we can learn a lot from what's going on at peers and apply that more broadly to other constituencies.
Thank you. Thank you so much, Director Wade, and to all on the panel. I'm very excited to be here and really appreciate the invitation. The Division of Mental Health, obviously, we are really committed to being a part of the solution for the workforce challenge. We have 7 state hospitals that we operate, and we also fund many of the community-based mental health services. So our stake in this isn't just as an agency. We are also are thinking about the workforce for our hospitals and other places as well. So we have a number of initiatives. Much of it is tied to the legislation that Blanca talked about before. We are funding the Behavioral Health Workforce Center, which will sort of be a home for a lot of these initiatives, really help to give us some synthesis of information, help us understand the information that we have, the information that we have yet to collect, and really inform the work. So we're moving about in a data-informed, data-driven way. We are also supporting the CRSS credential. And as a part of the existing publicly funded mental health service framework. So as was mentioned, ACT services, mobile crisis services, a part of that is us making those roles a part of those programs is a way to jumpstart that credential and then that part of the workforce and give them entree into actual jobs, actual job placement models and programs. And so we see that as a huge part of the overall workforce strategy, but also to lift that subsection of the workforce, the behavioral health workforce as well. We are looking at sort of the broader category of folks who are, so in the workforce, you have those who are licensed as kind of one tier of the behavioral health workforce. You have those who have completed their education requirements, but yet have yet to get licensed. And then you have those of CRS, Certified Family Professional, CADC, Certified Alcohol and Drug Counselor, right? That part of the workforce as well. So we are looking at ways to really kind of explore that tier, really all of the tiers, but we're having a lot of emphasis on that tier as well, which is, really a part of this particular conversation, which is why I'm really excited about a chance to kind of talk about it. But at a real high level, those are some of the strategies we're working towards to stabilize and expand the workforce and to prepare for what we see coming down the road, some of these new initiatives and opportunities that are nationwide to help the state of Illinois be in the best position possible.
So I wanted to ask a question. There's a $8 million RFP out there right now that will go directly to expanding the CRSS world. So this will bring some new people in or enhance the credentials of some people already doing things. How many, out of the 8 million, which will be granted out to a lot of different folks, does the department have a target number or an estimate for how many new folks we get from that?
I'll have to sort of preface my statement by saying that it is an active RFP that's out there. So I'm very limited
in ballparking, right? Yeah.
In what I can say about it. But I do invite people to go to our website, look up the RFP. You can see the requirements there and learn a lot more about it. But broadly speaking, let me not try to handicap. Let me just say that we want to bring in, expand that opportunity. It could potentially yield several hundred or so folks who come into the programs and take advantage of the workforce. So I'll just sort of say it there. We have high expectations. We're really hoping that it is a success and continue the effort of moving the CRSS credential and fielding it out into the workforce.
This is great. So it sounds like you are really fleshing out a model of talent development. You're using one piece of the workforce, but other, this could be applied in a lot of different ways. And you've got an RFP for an initial group, and hopefully people will be able to figure out how to turn 8 million into 1,000. but it's 8 million, and it's, you know, if we're in the hundreds or low thousands, is that adequate to the need? One of the things I wanted to ask Pryscilla, you know, Pryscilla, when you began your work on population health, another category that's broad, and we're trying to learn about the mental health workforce, how did you find out what the need was, and what did you learn?
The need within behavioral health specifically?
Yeah, I mean, when we're scoping this out, what did you find? Because I want to get at what do we need to know, and what are the obstacles? Because it seems like there's a need. Did Dr. Barnett just meet the need? Like, how many do we need? Do we know that?
Yeah, hi everyone, I am representing Sinai Urban Health Institute. And so just to give a little bit of preface, we are working specifically on a grant to provide an entryway for Latinx job seekers into population health careers. And so basically how this whole initiative started was convening an advisory committee where we tried to define what population health careers were that were non-clinical. And so one of the biggest entryways that we identified was through community health worker model. And so specifically, we identified 3 different tracks of training, and one of the fuzziest that also had the biggest push from our advisory committee was this field of behavioral health. And so as somebody who has, you know, my experience in behavioral health only dates back 6 months probably, I really had to do a lot of research to try to map out what are the roles that are available to people who are not licensed, who are the organizations that are hiring for these roles, what are the education requirements, what are the, you know, the similarities and the differences between the skills that are needed and then the roles and the responsibilities. And my notes are just all over the place. There's so many different job titles. A lot of the skills and education requirements are very similar, but they also differ in a sense.
Yeah, we have a slide. Ed, I'm trying to say, I don't see the slide visible.
A screenshot of my messy notes.
Yeah, I apologize. Were our faces visible the whole time? I hope we weren't just looking at a blank screen. Go to the next one. This slide was a number about some of the inequities, which you kind of talked through. Pryscilla did heroic work finding out what?
These are just notes, finding out very, very little. So I was doing job searches essentially and finding, okay, these are some of the job titles. Here are some of the organizations, the requirements. I mean, this slide continues, you know, into what are the roles and the responsibilities. And so I was really just trying to see how they overlap. And as somebody who comes from more of a community health worker background, I identified that a lot of the responsibilities of these workers are hand in hand with what community health workers do for things like diabetes or asthma, different kinds of health issues. Okay,
I think we can take the slide down. I just wanted to, I asked Pryscilla for this and she was hesitant because it didn't look good. But the point that we wanted to get is that there's an enormity of this. And I think the question about how many do we need has been one challenge, knowing that. The other challenge has been just the enormity of positions, particularly at the front end of the talent pool. And, you know, if we want to build diversity into the mental health system, we need to start where people are. And we have people that are in roles right now. I'm not sure the slideshows are going to work, but I know one thing that was on one of the slides that Blanca had was, could you flash up? I think it's the next one. It talks about percentages in the workforce. I'm not able to see. Yeah, oh, good one. Okay. This I thought was really interesting. Blanca, did you do this is this from the Michigan study? How do we know, where did these numbers about percentages of psychologists who are people of color? Because I know Illinois doesn't report that.
So this is from the APA. So this is a national number. And so what we learned from our work with the task force is that, you know, a lot of data is not collected. So it is my understanding from Dr. Barnett that they do collect some demographic data for psychologists. We understand that that's not across the board throughout the different provider types. So we know that, for example, for physicians, we know how many physicians we have licensed in the state of Illinois. We don't know how many psychiatrists we have. We don't know how many child psychiatrists we have, right? So there's the data piece we found to be a huge issue here in Illinois, something that the behavioral health, as part of the charge and the RFI that was issued, will be tasked with doing, sort of collaborating with IDFPR, with the other certified bodies, to ensure that we are indeed collecting that data, and not only collecting it, but using it for strategic planning and workforce development efforts across the state.
Okay, that's great, because the point I think to take from this is that right now we know there's enough need just by going to the community meetings that Pryscilla was convening, and just by hearing SEBA talk about how many unfilled jobs there are. We know that there's gigantic need, but when we get beyond sort of initial scale up or trying things out and need to go to scale, we need hard data. Because we can learn a lot from it. What I didn't know is that 84% of psychologists are white, but if you go to under age 36, people of color represent 26% of psychologists. So it does show that earlier on, younger psychologists, there is some progress there. But if we're going to accelerate and scale up, we've got to look, you can take the slide down, at the front end of the workforce. I mean, 26% is okay. It's actually kind of remarkable if that were to extend out and be the whole field, because I'm not sure, well, actually, no. If 26%, we're probably 40 representation. The point of it is the front end, at the front end, where people start, where people are. It was really hard to get a picture on it. I was working with a workforce organization, and they said, well, they train nurses. You go in as a nurse assistant, the first thing you get is a nurse assistant. Then you do some community college and you get an LPN, and you can work all the way up to RN. It doesn't seem like that exists in the same way. It doesn't seem like the mental health community is using that capacity from those other organizations that could help. And when we were trying to figure out, okay, what would we do? We could create a program. We didn't know what to train for. So,
that's the similar boat that we're in at Sinai Urban Health Institute. We're trying to create a role that doesn't really exist, even though it does exist just in so many different job titles, where you're training on the same things, but what do we, I mean, you're looking for the same skills, but what exactly are we supposed to train for? There's not a long list of boxes to check. But as far as pathways, maybe Dr. Barnett can speak a little bit more about a pathway that does exist that I found in all this research, which is billing as a rehabilitative service associate. With 5 years of experience, you become a mental health professional. With a bachelor's or a master's, you become a qualified mental health professional.
That's
For me, it's a beautiful path that exists that I don't think people are really taking advantage of.
Yeah, thank you. That's a great question. So it's just kind of stepping back a little bit, the mental health authority, the rules that govern mental health, publicly funded mental health and Medicaid in the state of Illinois carve out different categories or different tiers of providers, mental health providers in the system. The top tier being those who have the highest license in the state. So psychiatrists, licensed psychologists, licensed clinical social workers, licensed clinical professional counselors. They sort of sit at sort of the top tier. The next tier under that is what we would call a QMHP, a qualified mental health professional. Those are folks who have a master's degree and are on their way to get licensed, or they currently have sort of the lower license of the overall structure. And then under that is the mental health professional, then RSA. CRSS, CADC, a number of these other quote unquote peer models sit in that MHP category. Now, that category, based on the Medicaid rules, can do a number of different things that are billable services. The challenge tends to come when the person lands at a particular employer, whether or not employer wants to, how the employer wants to use the person who has that credential. And so, to get to kind of Pryscilla's point earlier, if the person gets an opportunity to do a range of skills or activities at a given employer, they build competence, they build skill, they build these kinds of things, which then sort of sets up a situation where they may, go back to school and reach for the higher credentials in that tier. I think that this is kind of where it connects to a point, Andy, you made earlier about mentoring. So as folks enter in the front door, what kind of experiences they have that would then create more pathways to higher levels if they want. And we shouldn't make the assumption that everyone wants to, become a physician or a psychologist. We should, that's an assumption, but the pathway would be there with the appropriate structures and mentoring.
I want to jump on one thing you said earlier in one of our, when we first met. You said, talking about things that were emerging from communities, because one thing that jumped out when Pryscilla was mapping, because she was really with a bunch of community health people, community groups, and just starting there, and some of the big mental health providers, a ton of job titles I haven't even heard yet. Like, what's a life coach? A friend, the guy who I wanted on the panel couldn't make it, was Ashley Miller from Chicago Cred, which is doing life coaching with, mostly young men that have come out of incarceration, and they're doing wonderful stuff. And he's in school, but he's not quite there yet. I'm not sure what he is. What are these Can you talk a little bit? You said you'd seen things coming up out of the community. You framed it really well. I'm trying to remember how you said it. I mean, I guess
was that
I'm asking you, I don't think we were at a point where we have a plan for that talent, right? But you had talked about things that were emerging from community. I guess what I'm asking is, does DHS have that part of it figured out yet?
We are exploring opportunities. We certainly obviously partner with many organizations, SEBA included, many organizations to kind of advise us a lot of about opportunities that's happening on the ground and in various communities across the state. Our Funding the Workforce Center is another way for us to be informed about opportunities and models and initiatives. So I think, to answer your question, I probably can't say that we have figured it out, but we are definitely in a position of exploring opportunities and exploring innovative ways to do this. And with keeping in mind that our main primary mission is in the safety net services, publicly funded safety net services, the world of behavioral health certainly extends beyond that. But to the extent that we can play our role in the overall behavioral health workforce, we're certainly looking at opportunities to do so.
It sounds like there's an opportunity for collaboration across our sector. And maybe I was just curious, because there's this, we need a lot of talent. And, one thing that came to me over this week when I was trying to figure out the funding stream was there's actually literally different worlds. The mental health workforce world. And that, as I begin to think about that, that's why I got so confused. It's like, oh, the mental health workforce world, people are working on it. Then there's Pryscilla's world, which is, I'd say, community health. And then, frankly, there's this whole other workforce sector that is not necessarily training for mental health. They do get in some health professions, but they're actually really good at working with people who are coming from challenging circumstances. And it seems to me that there's a huge base of talent if we could only harness it. And so maybe we'll table the one that's not there yet that we know is an issue to hear about Pryscilla, because it seems like community health worker is really developed. And there's a moment, and somehow it fits into this. Let's assume that it will figure out the path. But could you tell me a little bit about the community health worker? We worked with you to work on the mental health piece of your main program, but why don't we talk a little bit about that? So I'm going to get your slide up, okay? Pryscilla, go.
Slide. Oh, well, this is just outlining that that the original project where I said we are developing 3 different specializations for community health workers. Just a training program to train and place Latinx job seekers with a high school diploma. So these first 2 lighter blue boxes are roles that exist. The traditional community health worker who's focusing on education and health promotion and outreach. And then this middle box, this middle shade of blue is what you would know as like a care coordinator, somebody who's linking people to resources. And the third box is behavioral health. I think there's a very strong opportunity for us to train community health workers in, specialized and targeted behavioral health training, to deploy a larger strategy of getting people into this workforce. These positions that Dr. Barnett is describing, the CRSS, the CADS, am I saying that right? Certified
CADC.
CADC, sorry. Those roles, they require lived experience, but community health workers are, coming from, they're either members of these communities or they have an unusual familiarity with, the communities that they're serving. And I think that's really important to build trust and to kind of support people along their path to recovery and just building up their resilience. Yeah, and I'm curious to know if the CRSS type of role is an MHP, is a mental health professional, then what is an RSA? Because I think there's an opportunity to, train community health workers in behavioral health, build them either as community health workers or as RSAs. And then instead of waiting 5 years of experience for them to progress into the next tier, creating some sort of apprenticeship where they're becoming certified, where they're getting that mentoring and they're learning those skills and then progressing to the next year. And using that workforce language, Andy, that you were suggesting earlier, like apprenticeship model. That's what we're exploring at SUHI, at least. So we believe in the model and we think that this is a good opportunity to use it.
Well, the other thing is those models are funded. They tap a different source of funding, the Workforce Innovation and Opportunity Act, WIOA. And so I know one of the issues is we got to our 3 pillars is how do you pay for this? It sounds like there's a lot of things that aren't paid for by Medicaid. Were you asking Dr. Barnett a question about how RSA fit into this? Because I don't understand.
Yeah, what are those job titles? If they're the kind of the entry, and I thought CRSS was the RSA role, but I guess it's not.
You can take the slide down. Thanks.
Thank you.
Yeah, no, it's a great question, and I think it really taps into Andy, something that you mentioned earlier about who's not a part of the conversation and adjacent parts of the overall workforce that are have different pockets. To get to Pryscilla's question, the CRSS is a part of that MHP category, and RSA is a separate. So I said, there's the LPHA, that's one tier, QMHP is another tier, MHP is another tier, and then RSA. But one thing I did want to mention, I think is important to this conversation, about 3 or 4 years ago, the state of Illinois passed the Mental Health Early Action on Campus Act. And part of what that bill did was it called for basically peer counselors as a part of college mental health programs. Now, that's not a part of what we do at DHS, at DMH DHS, but to sort of get to this point, they use peer to mean the classic term of peer, right? You are my peer or colleagues on two students. One student has some training and providing some wellness, mental health kind of support for another student. And I raise that because it speaks to sort of this idea of the notion of providing mental health support that does not come from a licensed clinician. That notion exists in lots of different spaces, but they're not necessarily a part of these kinds of conversations. But it sort of opens the door for what Pryscilla is proposing and others. Where do we find people who have a baseline level of training, talent, or some sort of certification that's standardized, and apply that talent to what we see in where there is mental health demand, wherever that may be.
It sounds like there's some bridge building and charting that needs to happen. One of the things as I begun to try to, come down the journey is meeting with people who prepare medical professionals, one group. And also, I'm fortunate that I've had the opportunity to work with people from that other group. I'm not a member of it, I'm a guest, but there's a lot of bridge building, I think, that can happen fairly quickly. It seems like it's there. I mean, we had some of them on the keynote yesterday. They're pretty close to ready to go, or they're going to something, but they're building it to be professional in the thing that they're defining. So it's how do you weave this quilt together? And it starts with, you find out who's got a thread. So the Workforce Education Center can't get there soon enough, but the thing that I think is we shouldn't wait. We should begin working on this outreach right now. Charting has been a thing. Does a chart exist where it's where everything fits in relation to each other? And it just in the mental health space, does that chart it out? I think that we were looking for it. I think it's one of these things where, it's like, you can't really do it. And I think the reason you can't do it is because the data and the enormity. But I think that this is a project. It's a large project, but it's a doable project. Other fields do it. We can. The reason I say that is that if we wanted to tap some of those other sectors and those other funding streams like WIOA, they pay for training, they pay for wraparound. And so that's a capacity building machine that can be helpful when we're ready to scale. Because the funding seems like, it's Medicaid, you're Medicaid eligible, and community health workers will be Medicaid eligible. MHPs are all MHP categories, Medicaid eligible. So is like a life coach Medicaid eligible?
I don't think so. I don't know much about life coach, so I don't want to speak out of turn, but I don't think that's the case.
Okay.
That's the thing for me. We don't start with WIOA. We start with the employers and establishing the role that can serve as the umbrella for all of the different job titles that people are using. But we have to get employers on board to use these, this talent from the community to provide the services.
And it all ties back to funding, right? It all ties back to funding and ensuring that the resources are there for employers to be able to, in our case, for example, just to bill for Medicaid. You have to be able to bill for Medicaid. Otherwise, like you said, we have all these different funding streams. We have some grants. So for the 590 program, for those unfunded folks, providers are going to be using the 590 grants that DMH has issued, but that funding piece is critical to ensuring that we are able to staff up, to beef up this workforce. That is essential. It is key, and also for the employer side, but also for the individuals, right? As a Latina, like coming up, I didn't have, and not just my personal experience, and it's not everyone that has. My parents didn't have a college fund for me, right? So creating those opportunities for communities of color and ensuring that there is indeed loan repayment, that there is that financial support targeted at these communities, because obviously, their experience, their presence is so much needed across the board. So I think that is so important. So the resource, whether it's the individual and also for the employers, it's key.
Yeah, no, I think it sounds like there's another, program or sort of, I think we could do a webinar specifically on things like, we have to do it because if people aren't at this table, there's a table that we have to find. And if it doesn't if it doesn't exist, maybe we can help. Because I think, just in knowing people as friends, I just see like enormous talent, and it shouldn't be so hard, I got to say, I'm blown away by what some people do and what they accomplish. And, so people who make it are really impressive, but mere mortals, and I think we're all mere mortals, but if we have to know what to invest in, and so I'm thinking we should do another webinar just on communities that aren't at the table.
Yeah.
Say,
I think because of COVID and just in the past several years, the conversation about mental health and it's just top of mind for everyone. It is top of mind, obviously, when we're talking to the general public, but when we're talking to legislators, and it's actually really reassuring that they understand that this is a problem. It is a problem that has been here for a really long time, and we're just now more openly talking about it. And I think COVID did definitely heighten that. We're starting to, stigma is still there, especially in communities of color. Stigma is still there, but I think we're starting to chip away at that. So we have high profile folks. Both of our two past Governor Pritzker and our previous governor both talked about their own family experiences with behavioral health care issues. So I think it is so important. We are at such a place where there is opportunity to advance our issues. I think there is a willingness to invest in supporting this infrastructure. So I think I'm hopeful. I'm definitely hopeful that we are moving forward in the right direction.
So I want to encourage people to stick around. I know this is the thing with the virtual conference, and this is the reason why we really need to do a push conference to make sure, you actually, if you're a part of the conference and have the link, you can watch any session for up to a year. And we're going to try to figure out how do we get that out there more, because there's a valuable conversation coming up, but there's 5 workshops. And if you want to choose one of the other ones, but the legislators, we have the chairs of both mental health committees are teeing up one of the next sessions. We also have immigrant mental health. I think is at the same time as this, which I really wanted to go to, because there's some really good work happening. And I think right now, because we had technical issues, we need people to go. But so any final thoughts? I think we're at the point where we need to wrap up about where do we go from here? I want to start with Dr. Barnett and Pryscilla. Let's go in order. Where do we go from here? What's next? What needs to happen next?
I think it is important that we really spend a lot of time understanding the data environment, what we know, what we don't know, and kind of building out that groundwork so that we have a good sense of where it's best to spend our efforts. As we do that, we are also taking stock of what are the existing behavioral health challenges, and I want to sort of emphasize not just behavioral health as classically defined, but also sort of the broader idea of wellness, right? So not everyone has a diagnosis, right? But there are still needs that need to be addressed that's not necessarily diagnosable, but kind of taking stock of that and thinking about what we see coming down the road in terms of the mental health system and its ability to meet the demands that people are raising their hand saying that they're having, whether it is diagnosable or not. So those are sort of two things I know that we really have to spend a good deal of time on in the immediate term.
So, Pryscilla, I want to add, I do apologize. We didn't have the Q&A format. We could talk about this for hours, but I think that we were having a good conversation about it. There was a statement in the chat which raised an issue, is that sometimes training CHWs can end up being overqualified as RSAs and then go lower payments. I'm not sure exactly what that means, but it sounds like what the person who made that comment, oh wait, here I'm reading this. I can't see the entire chat, but it does seem like there's a lot of knowledge there. Has this come up in your explorations?
I'm not even sure how much RSAs are billed for. I was looking for any opportunity to make it more sustainable. But if we bill Medicaid for a behavioral health specialized CHW, that the Black Caucus just got the HB 148 passed in March. And so eventually we'll have a statewide certification for CHWs to be billed under Medicaid. Hopefully it will be more than the RSA. I don't know what the RSA amount is, but yeah.
Well, I'm looking at who is in the chat. I mean, we've got some people. I think I see city colleges. I see the psychiatrists. I see, Tricia Hogan from the Peer Association. It sounds like maybe there's a lot of folks that have knowledge about specific issues, and there's a lot of specificity in all of this work for it to succeed. But the architecture of inclusion is, needs a committee. So, Eddie, just as in rethink of where do we go next, it does seem like I would like to convene back with the people who are on this group and the other one to try to come up with what are the recommendations that we ought to get consideration for. But then I think we also need to reach out to people. If this is a live meeting, we would be able to have them like a real meeting in person. We could talk to them right there. But to really invite back the people who are a broader group working with it and get some help on this. So maybe that's a commitment NAMI will make, is that we'll get the notes together into some form of coherence to get them as draft things that we should work on, and ask the people who have been in here but aren't on the panel, because they're frankly know more than we do in a lot of things. And then also some dedicated outreach to the folks that aren't at the table. So we have one more minute. Blanca, you want to have a last shot? Where do we go from here?
Where we go I'm a policy person, so we are currently working on our initiatives for this coming session, and the behavioral health reimbursement rates for Medicaid and the workforce are top two priority initiatives. So you will see some legislation coming from CEBA to address some of these challenges, but very hopeful again about the work of the Behavioral Health Workforce Education Center and the potential to bring all these folks, right, that we're talking about right now, all of us, to bring all these folks to the table and really look at addressing the different pieces, because we're talking about a lot of different provider types, and we're talking about behavioral health care. We're talking a lot of different things, right? We're talking social determinants of health that we didn't even touch upon, so many different things. So I think so many more conversations need to happen, and really developing a plan and pushing on a united front to enact some of these, whether it's working with Dr. Barnett at DMH, with HFS, via the legislature. But a lot of opportunity. I definitely see a lot of opportunity.
That's great. I just want to thank everyone. It seems to me a thing that I'm taking away from this is there's a absolutely will to work together for coherence. And just by trying to articulate what we've been trying to articulate, I actually feel like we're more clear than we've been in some of our earlier conversations. But we need to write it up and invite some folks to the table, because we need to figure out the role of, traditional models like CRSS, adjacent models like community health worker. I will say community models, maybe, of the people who are inventing some of the most inspiring work that you'll ever see, who ought to be here. So it seems like there's the development of the models in the pipe. A lot of work's happening that can be connected. But I do think, we need to articulate this. I would love to see the chart. And I think that that's something we should ask someone to help us to do the project to chart this, to map this out, because then we can help. Maybe this is a Workforce Education Center project, or it's something we do to contribute to that. So whatever it is, thank you all. NAMI Illinois is in it to win it. And I think that we should, I think we're done. I hope people will stick around, and we can debrief by email. All right. Thanks, everyone.